isn't really that much of a mood elevator like the other drugs of abuse. And I think through multiple channels, I think that led you into what you're doing now, these large clinical trials and other types of studies to leverage what we know about basic research and basic mechanisms underlying cigarette addiction to translation to policy. So, yeah.
Great.
But we're all glad to hear it.
Yeah. Thank you both. Let's try not to mess this up since we're good now. So yeah, so what Alan said is really accurate. I mean, it's weird for me to find myself in a place where my work matters from a policy perspective. As somebody who trained in an animal lab, thought of myself as kind of a classic behavioral pharmacologist, right up to the point where suddenly behavioral pharmacology mattered for policy, and then trying to redirect and understand how that plays out in the real world. Like, how do you actually do regulatory science, but still be informed by those behavioral kind of pharmacology roots? So I'm going to talk a little bit about that, but mostly I'm going to be pretty practical today. So before I get started, I want to acknowledge CNIC is a nice, huge, wonderful group of people that I've been completely privileged to work with. I kind of sit back sometimes and go, holy mackerel, how did I end up working with these folks? And so I want to acknowledge all that they've done for my career as well as for the projects I'm going to talk about. So, okay, well, here we go. Today's an interesting day to be giving a talk because if you didn't hear, today the advance notice for proposed rulemaking came out on nicotine reduction. Again, kind of hard to imagine this is the day we're living in. All of a sudden, not all of a sudden, but it feels like a little bit, FDA is moving forward with this potentially radical idea. An idea that's been around a long time, but it's still pretty radical from a policy perspective to reduce the amount of nicotine in cigarettes. And so, certainly that idea has been around a long time, and what I want to do is kind of make sure that we don't think, and that when you think about nicotine reduction, you don't think about it just in the sense of what trials have been done on reduced nicotine cigarettes. I think those are important trials, and certainly that's where we're focusing our efforts. But this idea that nicotine is central to why people use tobacco, which is really the core idea behind the policy, has been around obviously a long time, both from the industry perspective as well as researchers. And so these are some well-known quotes. The one from William Dunn, I think a lot of people know, without nicotine there would be no smoking. This is actually my favorite one. The goal is to determine the minimum, not maximum in their case, but minimum amount of nicotine that will allow continued smoking. So they, Lorillard was recognizing that they couldn't go below a certain point, but if they kept it above that, they could keep the behavior going. We want to know the opposite. We want to know what happens if you get below that point. Does it stop? And then from a researcher perspective, certainly we've known for decades that nicotine is the key reason that people use tobacco. That was summarized in the 1980s in the Surgeon General's report. And so it's been 30 years since, certainly at even the most comprehensive level, we've made this conclusion. But you can go back to the 20s or the 40s to see evidence that people were pretty certain that this was the main reason people used tobacco products. So when we think about a policy like nicotine reduction, we shouldn't fall into the fallacy that it's based only on clinical trials of reduced nicotine cigarettes, because it's really based on decades of research that suggests that nicotine is key. Right? So what I want to do today, so what I want to do today, yeah, go ahead.
Has anyone been saying nicotine is not key?
Not anymore. Not since 1994, that famous stand up in front of Congress and swear it off.
It's not addictive.
Right.
But did anyone actually ever say that people smoke other than to addict or something not related to nicotine?
Absolutely. So people say to me all the time, and in fact, as Adam alluded to, my work really has focused on the other reasons people smoke too, which is true. We know that people smoke because of sensory perceptive reasons, conditional reinforcement, and social reasons. Those are all factors that influence smoking. The question is, are they sufficient? Are they sufficient to maintain it over time? I think that's the difference. So in a particular situation, especially with youth, nicotine reduction is not going to stop a kid potentially from trying a cigarette, but it might stop them from becoming a chronic dependent smoker. And so I'll go through the slides today, but because this is a pretty informal atmosphere, and certainly with the advance notice coming out, I'm happy to kind of get through whatever I can in chat. If people want to ask more and kind of dig into something, that doesn't bother me at all, so feel free to interrupt. So this idea of nicotine reduction has been around a long time. So certainly, as I mentioned, the idea that nicotine is key has been around for decades. But even in the 90s, the FDA was pursuing this idea of potentially reducing nicotine in cigarettes. And so this was, basically during the days in which David Kessler was investigating the industry as commissioner of the FDA. And what he was finding was that the industry had manipulated nicotine levels in all sorts of ways, right? So they had changed the product characteristics. They had tried to understand how to pick the right leaves, breed the right plants, adjust the pH to maximize nicotine delivery. And so this made him kind of, pay attention to it as a drug, that this is a drug delivery system. And therefore, if it is a drug delivery system, and we think about it from an abuse liability perspective, then maybe we can understand how to limit the abuse liability and have people kind of be free to choose to quit a little more. And so he went to Neil and Jack, so Neil Downs and Jack Henningfield, and asked them explicitly, how much nicotine does it take to cause addiction in a cigarette? How low, what do we know about that? And so what Neil and Jack did is they went to the literature on chippers, and they said, okay, what we know is that there's this group of people that don't seem to become dependent like other people. They use cigarettes, sometimes for many years, but don't experience the same symptoms. They don't escalate how much they use. And maybe if we knew how much nicotine they were exposed to, and then worked backwards to figure out how we could engineer a cigarette so that nobody else could be exposed to more than that, then we could come up with a level that would avoid dependence in everybody, or in most people. And so they did that math. They kind of used what they knew about exposure in these chippers, used what they knew about the nicotine content of current cigarettes, and about nicotine bioavailability. So if people got the most they could out of a cigarette, how high could they get their plasma levels to be? And they reasoned based on that if you could draw a limit of 0.4 to 0.5 milligrams of nicotine per cigarette, that you could potentially reduce addiction in current smokers and avoid it in the first place. And so that, just for reference, that is, most cigarettes have somewhere, so let's just use 10 milligrams of nicotine. So that's about the right ballpark. So talking about a sizable reduction, a 95% reduction in the amount of nicotine in a cigarette. So they put this forward in a New England paper, New England Journal of Medicine paper in 1994, and it shortly thereafter was supported by the American Medical Association, was getting a little bit of traction with the FDA, and then the FDA failed in its attempt to regulate tobacco products, right? Because they were trying to regulate it as a drug, and the Supreme Court said, no, that's not what the Food, Drug, and Cosmetic Act intended, and so they pulled the authority out of FDA until 2009, when Congress explicitly amended the Act to include tobacco products, right? So in 2009, the landscape shifts. Now, they're going to allow nicotine to be a potential target of tobacco products. So they're going to give the FDA the authority over tobacco products, and explicitly in the Act, call out the potential to limit the amount of nicotine in a product, including cigarettes, if it would reduce addictiveness and improve public health. So all of a sudden, in 2009, we have the authority to do this thing that had been contemplated for many years before.
Can I ask just a random question?
Yeah.
But they're not allowed to reduce it to 0, right? Where did that come from? Why can't it be 0? Why does it have to be a minuscule amount?
Right. So, do you want my cynical or non-cynical answer?
Cynical.
Right. So my cynical answer is the industry absolutely put it in there so that they could sue the FDA and say that's functionally 0, whatever standard you put. And so I think that's something we have to be aware of, right? My non-cynical side would say that 0 is an indefensible number. There's always trace amounts of something, and so 0 is meaningless in a product like that. You can't functionally achieve 0. And so, even if you try to extract nicotine, there will be some left. And so it was not a feasible option it would be technically infeasible.
It's also early on, I invested with Zalaga when he was talking at TCORS at the beginning, because it seems counterintuitive to what we do. And he said the way the FDA is structured and the way they're defining tobacco products as a product, it comes hand in hand with the nicotine level. So if you had 0, it would no longer be classified as a tobacco product.
Right.
So, there's a legal terminology and structural restriction there on the way it's set up.
Right. And so it is a critical issue in terms of predicting how this might proceed. That if the industry can make the argument that it's functionally 0, then they could say that it actually is illegal, essentially. It's beyond the regulatory authority. So one of the things in the advance notice, I read it briefly on the plane, but one of the things I noticed that was in there was a reference to Arthur Brody's work showing that you do get nicotine receptor occupancy in low nicotine cigarettes, suggesting that there's a physiologically measurable effect. It may be below what's necessary for reinforcement, but it'd be hard to argue that's 0, right? And I think that's, we need to think about data that suggests it's not 0, but also would likely reduce abuse liability. Okay, so what I included today, if we can get through it, but like I said, I don't mind either way, is to talk about these things. There's a lot of topics that come up related to this potential policy. These are just the ones I pulled out for today. So one is how low do you have to go and what's the effect? The second is this issue of compensatory smoking. Do people compensate by changing their behavior? The third is what's the impact on vulnerable populations, particularly those with comorbid psychiatric disorders. The fourth is the potential need to educate people about the policy and how we should frame it. The fifth is how should we implement it? And the advance notice raises this issue as well. Should it be done gradually, kind of in the most, think about it as the most humane approach, like step people down, or should it be done abruptly or immediately? And finally, and I think an issue particularly relevant to you all, is what's the role of alternative products in this, and how do we view that as part of this policy discussion? So let's talk about nicotine level first. So this is the study that we were referring to earlier, that was published a couple of years ago now, where we randomized 839 smokers, that were all adults, all daily smokers, generally not using other tobacco products, and they weren't interested in quitting. So this is important. This is a policy-related question. This is not an efficacy or treatment question, right? That's a different target. And so we recruited from 10 sites around the country, so big multi-site trial. And what we did is we basically provided people free cigarettes, study cigarettes, for a 6-week period of time. So we did a baseline assessment. Then for 6 weeks, we gave them all the product that they wanted in these groups that I'll show you in a second, and basically measured changes in behavior, changes in exposure in terms of certain biomarkers, potentially any unintended consequences. We measured things like cognitive and affective changes and so forth. All the subjects received whatever menthol version they preferred, so they got a menthol or non-menthol version of these cigarettes, and this was a double-blind study. And so these are the groups people could be randomized to. So there were 7 groups in this trial. We had 2 control groups because we could see the advantages of both, and so I was joking with Adam earlier about how I still think like an animal behavioral pharmacologist and want to include all the groups, and so we included both control groups here. So some people were lucky enough to get free usual brand cigarettes for 6 weeks. Other people got a Spectrum cigarettes. These are the NIH cigarettes that are available through the NIDA drug supply. But they had normal amounts of nicotine in them, and this is about 16 milligrams per gram of tobacco. And then there were 5 experimental groups that received reduced amounts of nicotine in their cigarettes, from about 1/3 of the nicotine that's in the control groups all the way down to only 3% of nicotine. So when I talk about nicotine reduction, we're talking about not a subtle manipulation. We're talking about taking most of the nicotine out of the cigarette. Okay? You can see that we are not studying this space in here. And I can talk a little bit about that later on a couple other slides, but the concern in there would be if you only reduce it a little bit, people are likely to compensate. Okay, so this is the primary outcome, cigarettes per day. I apologize to those of you who've had to see this graph many times because I always show it. But the gist is this, we see over the course of the 6-week trial, the groups split into two distinct clusters. Those individuals who were randomized to receive a cigarette that was either their usual brand, a normal amount of nicotine, or the 5.2, the one that was reduced to about a third of normal, they smoked at a higher rate than those who were randomized to 2.4 milligrams or below. And it was this very interesting, looks like a threshold sort of effect. Like you've got to get to 2.4 milligrams, and if you do, you see a change in behavior over time. So this is really encouraging. It suggests that we can reduce the number of cigarettes people smoke per day by reducing nicotine. One thing to note, and many people do, is it doesn't reduce relative to baseline. Why? Well, that's probably because they're paying for them here and they're free here. And so likely this increase, as you can see happen in the usual brand, is a free cigarette effect, and we're seeing a reduction relative to that free cigarette effect. And in fact, we kind of know that because if we asked them, if you had to pay for these and say they were $6 a pack, what would you have done in this trial? They say, oh, yeah, I would have smoked far less if I actually had to pay for these cigarettes. So we're pretty sure, and we've done demand curve analyses, we're pretty sure that that's why they don't decrease relative to baseline. So interestingly, this sort of kind of bimodal split in the dose response curve, suggesting there's a threshold, is really similar to what we see in the animal model too. So part of my lab does animal self-administration work. So we teach rats to press a lever for nicotine. And this is what happens when you reduce the nicotine in a rat pressing levers. First, say they learn to press the lever at 60 micrograms per kilogram, a nice, good, strong reinforcing dose. And then we reduce them, and just like we did in the clinical trial, to different doses. And you can see that there's two clusters. If that dose gets below to 3.75 milligrams or below, again, more than a 90% reduction relative to where they were, you see a decrease in behavior relative to those who are maintained at a higher dose. So it seems to be that we can replicate this across animals or across species. That leads, as you might predict, to a decrease in exposure. We're giving them cigarettes with less nicotine, and in fact, we can confirm that they're getting less nicotine exposure by taking measures of their urinary biomarkers, and it's dose dependent. The more you reduce nicotine, the more their urinary biomarkers of nicotine exposure are decreased. Again, we've reduced how much they're smoking and how much nicotine they're exposed to. And then if we ask them measures of dependence, we can actually see decreases within a 6-week period in self-reported symptoms of dependence. This is the Fagerstrom at baseline and at the end of the 6-week intervention by group. And you can see that if you're randomized to the low nicotine groups, you see a significant decline in the Fagerstrom scores relative to those that were in the control conditions. And this isn't just true for the Fagerstrom, this is true for other symptoms or measures of dependence like the wisdom.
And what was the minimum cigarettes per day?
5.
5.
And if we take it one step further, at the end of that 6 weeks, they're reporting less dependence. At 30 days, we called them up after the trial and just asked them over the phone if they had made a quit attempt. And in fact, we did this kind of as a safety check because we'd been giving them free cigarettes. I wanted to know whether giving people free cigarettes for 6 weeks increases how much they smoke when I take them away again, right? So that didn't happen, thankfully. That absolutely doesn't seem to be the case. And in fact, what happened was, if you were randomized to those low nicotine cigarettes, even though I took them away at the end of the trial, maybe you had less dependence, and you went ahead and made a quit attempt more often during the follow-up period, even though you're back out there in the real world. I mean, they were in the real world the whole time, but you only have access to your usual brand.
Okay, so the quit attempts included what they usually would use.
Right, so at the end of 6 weeks, we took the investigational product back, and then 30 days later, we just called them and asked what happened. And so the only products were commercially available.
And they were still blind at that point to their...
They were still blind at that point, yeah, they didn't know what they went through.
Were you able to define, since this is based on self-report, what they really meant in terms of trying to quit? I would think maybe some people would say, oh, they wake up and they say, I really think I shouldn't smoke today. So they go 1 hour longer before they smoke. Or they just think about it and they don't get to the next step.
Right, all we know here is that they made an attempt to quit permanently. We don't know how long it lasted, and it certainly wasn't biochemically In more recent trials, we've actually brought them back in to biochemically confirm it. It's associated now, but we didn't think we'd see this, to be honest. So bringing 840 people back in after 30 days, we're like, oh, we don't need to worry about that. We just need to make sure we didn't cause harm. So this was a bit surprising. And this is kind of an important general point. When you think about whether nicotine reduction helps people quit, in these trials, they're all coming in saying they're not interested in quitting. And then you're sending them out in the real world where they have lots of other choices for cigarettes to use. And so studying quitting becomes very difficult because they can choose to smoke their Marlboros anytime. And I'm not interested in whether they quit more often when they have their Marlboros. I'm interested in whether they quit more often when they can't have their Marlboros, at least the normal ones. Right? Okay, so the truth is, even though more people made a quit attempt, you can see that it's still, the majority of people are still smoking. Right? The majority of people don't even make a quit attempt, and of course most don't quit. And so even during the trial, people are generally smoking these cigarettes. They're not magically stopping smoking. And so one way to try to understand what might happen over a longer period of time is simply to ask people, after there are 6 weeks of using these products, what would you do if this was all that you could do? And so we just simply asked, starting today, if the cigarette was the only type of cigarette that was available to purchase, what would you do? And so what you see is that in the lower nicotine conditions, over half of people say that in a year they would stop smoking. The second most common answer is that they would smoke less, and very uncommon is that they think they would smoke more. Right? So they're saying, yeah, this is essentially not good enough for me to try to compensate and smoke like crazy, and I'm more likely to probably quit. Okay, so this doesn't tell us a lot about cessation because, as I mentioned, it wasn't intended to do that. There have been a few studies that looked at quitting and have looked at whether or not using low nicotine cigarettes makes it more likely so that somebody can make a successful quit attempt. And there's really two ways you can do this. You can give it as a pre-treatment, right? So if I let people smoke these for a few weeks and then they make a quit attempt, are they more successful? Or you can give it as a relapse prevention tool. So that if you lapse these with these cigarettes, and maybe it's less likely to lead to full-blown relapse. Both have been done. The 3 relatively small trials that we looked at as the pre-treatment all suggest there's a likelihood of increased cessation, although I have to say all of them are essentially borderline or non-significant because they're just so small. They're also difficult trials to do because people aren't just smoking the low nicotine cigarettes then, they're smoking other cigarettes too. And then relapse prevention, people have done this idea where, okay, use this if you feel like you're going to have a craving or you're going to lapse. And both studies have seen an increase in quitting when people are told to use these cigarettes when they're feeling a craving or going to lapse instead of use a normal cigarette. So certainly evidence has suggested will increase cessation when people want to make a quit attempt, but not a lot of it. Okay, I'll pause there for a sec. Questions so far about any of that? Yeah.
Has anyone ever done the rat study where they follow them for 3 months, a year? In placebo, does it ever go down to nothing? They'll stop pressing the lever, don't you think?
There'll be some baseline rate of exploratory pressing, but at some point they merge with saline. So yeah, we have run out extinction studies on the order of maybe several weeks to a month. Keeping them longer than that is really hard to do. And it takes a long time to get behavior down because what happens is you get spontaneous recovery every time, right? You take them out of the cage and you put them back in and they press again because they're back in the context and they've been out of it for a little bit, right? So I don't think you shouldn't expect to see 0 because you don't even see 0 with saline.
Good.
Okay, so how about what would happen in a prevention setting? So this is a tough question to answer. So we come at it from a couple of perspectives. So one is we try to look at those smokers in our studies that are young. And basically, who are the young adult smokers and what are they doing in our trials? Because they have to be 18, so we have this group of 18 to 24-year-olds we can kind of pull at. So these are data from Rachel Cassidy, who had reanalyzed some of our data looking at this. And what she found was that very early on, by 2 weeks after smoking these low nicotine cigarettes, we can see that the youth are already reporting a decrease in the number of cigarettes per day. And in fact, it's bigger than the decrease we see in adults. So the decline tends to happen faster in youth than it does in adults. And we also see a similar effect when we ask them how satisfying the cigarette is. You see a really large drop in satisfaction ratings of these cigarettes, suggesting that the abuse liability is even lower in youth, if anything, and certainly not more. Because we'd be worried about this potential for the youth to be more sensitive, right, to low doses, and we don't see that. How about naive? So this is we were talking about this over lunch. This is the big question, right? So what would happen if a kid, that's all they could do is pick up a low nicotine cigarette? Maybe because they've never seen nicotine before, they're really sensitive. Maybe because they're young, they're really sensitive. And maybe that low amount of nicotine is still enough for them, right? And that would be a disaster, because the whole point is, in at least a large part, to prevent youth from ever becoming addicted. But maybe it's still enough for them. How do we study that? We can't ethically do it in humans. So we do animal models for this. And so we ask, do animals acquire nicotine self-administration at lower doses? And are youth different than adults in how low, and where that dose response curve is? Right? And so that's what these data are. These are adolescents and adults, males and females. And what you can see is that if they acquire at a relatively low dose, 10 micrograms per kilogram, that's a dose that supports self-administration in adults, so they'll learn to self-administer nicotine at that dose, but it doesn't support it in adolescents, suggesting that if anything, in our hands, adolescents are less sensitive to the reinforcing effects of low doses of nicotine. If that's true, that means that any policy that we generate based on adult data is likely to have a beneficial effect in youth too. Okay. So, first big point, this is the biggest section, that reducing nicotine to low levels, and we think down to 0.4 milligrams, because we think there's some potential additional advantages of going that low, is likely to minimize the addictiveness of cigarettes and maximize the benefit to the population. All right, this issue of compensation is a really important one. So what's compensatory smoking? So it's when people basically change their behavior to get more nicotine out of the product, right? And so we know this happened with light cigarettes. So light cigarettes are cigarettes that are ventilated cigarettes. They have the same amount of nicotine in the tobacco rod. They produce less nicotine when you measure it through a machine, when you look at the machine yield, because there's holes in the filter and the paper's more porous, and so the ambient air gets mixed in, the yield of the product goes down, and voila, it looks like it has less nicotine. But in reality, when people smoke these, they put their fingers on those little holes, they inhale more deeply, and they basically get the same amount of nicotine, because the nicotine's still there to get, right? It just takes a small change in behavior to get the same amount of drug. Importantly, these are not light cigarettes. These are cigarettes that have less nicotine in the tobacco. So it's not a trick, it's not some machine trick that the industry came up with to try to make it look better than it is. And in fact, if the user inhales a little more deeply or blocks those little holes, it's not going to yield more nicotine to them. Very small changes compared to how much we've reduced it, right? Because we've reduced it by, say, 95%. So they simply can't get enough nicotine out of these cigarettes. So we shouldn't assume that people will compensate with these low nicotine cigarettes like they do with light cigarettes. And this is really important because if I go out and talk to people about this is the number one thing they worry about. And it's because we've linked it to this history and we need to understand the difference. So a lot of studies suggest this doesn't happen, and that if anything, the only time it happens is basically the first couple of cigarettes someone smokes. They may try to inhale more, but then it quickly goes away because it's not very functional. Okay? And so there's a couple of, this is a study done in Florida by Dave McQueen, where he looked at the first 4 low nicotine cigarettes that someone smoked in the lab, and they did in fact inhale more volume of smoke for the first 2 cigarettes, but then by the 3rd and 4th cigarette, they were no different than the normal nicotine cigarettes. So compensation went away quickly. These are puff topography, or total amount of puff volume that from a cigarette that we took in that clinical trial. So this is a baseline, week 2 and week 6. And if anything, you don't see any lines going up suggesting compensation. What you see are lines going down, suggesting that they're getting less exposure to smoke per cigarette, not more when you reduce the amount of nicotine.
What is the HT friend for the point?
Oh, sorry, I skipped that. High tar. So we had 2 of these 0.4 milligram groups. One that was a normal ventilated cigarette like all the others, and then one that was a less ventilated high tar yield cigarette that we thought might make it more palatable tasting by decreasing ventilation. It didn't turn out to matter all that much. If you reduce the nicotine in the content, it pretty much has the same effect across most measures. Okay. And of course, we also don't see compensation in the number of cigarettes people smoke per day, which is the other way people could compensate. What we do see, so people don't change the way they smoke to get more nicotine. What they do is they go find another way to get nicotine. Right? So in our trials, the way they do this is they cheat. We say, please only use these cigarettes. Here's lots of Spectrum cigarettes. And they say, okay, and then they go out and they probably bum a Marlboro or have some still at their house and have a normal cigarette occasionally. And so that's another way, a much more effective way to get their nicotine back. Right? And so when we try to estimate how many people cheat by biomarkers, these are 3 different biomarkers that we think are sensitive to cheating, the use of non-study cigarettes in the trial, we think about 75 to 80% of our participants are cheating at least some way. So the majority of people are not like walking up the door and going, hey, this is totally fine, I'll just smoke those. Yeah.
What would the blood level, I can't read, NNAL, what would a blood level be if people in that original, in your 2015 study were not cheating? Would it be 15? Would it be much lower than that?
So they would be, I can't remember the numbers, but the relative decrease.
It was 50% for the usual smokers. It was on figure 2A, it was 30. And then for the people who went down to 0.4 milligrams, it was like 15.
Right. Right, so we would expect, so the tricky thing with NNAL is NNK is reduced in the product. So, because it's a byproduct of nicotine, right? So if you reduce NNK, so the product has less NNK, you're going to get lower NNL, even if you smoked only those cigarettes and you smoked the same amount. So that decrease, that 50% reduction, is partly due to reduced smoking a little less, but also partly due because there's just less NNK in the product, and therefore less NNL in the urine. Does that make sense? So it's a different kind of, it's not a real good biomarker of smoke exposure because it's actually reduced in the product.
Do you have a better, was there a better?
So I'll show you some data a little bit of metabolites, mercapturic acid metabolites, and those are better. So the gist here is that most people cheat, okay? And so when do they cheat? They mostly cheat, so the truth is most of them cheat at least probably 1 or 2, maybe 3 times a day. We don't think it's a lot more than that for most people because most people show us a clear reduction in their nicotine exposure. It's just not as low as we thought they might go. Right? Mostly those who are young and mostly those that tell us that they found the cigarettes particularly unsatisfying from the beginning. Not shocking. And when were they most likely to cheat? At least by self-report, first cigarette of the day, right? That's the one that they wanted their own Marlboro. They weren't going to smoke that lousy Spectrum. So I think there's really very little evidence that people will compensate, but there's certainly evidence that people are going to seek nicotine in some other form. Okay, vulnerable populations. How are we doing time-wise? Okay. So there's lots of potential, there's vulnerable populations that we might worry about with nicotine reduction. You're forcibly reducing nicotine exposure to different groups of people that could react differently to that through a policy. And the one that people probably worry the most about are people with psychiatric comorbidities, right? So we know that about half the cigarettes sold in the United States are smoked by people that have mental illness problems. And that the main reason we worry about nicotine reduction in this population comes from the hypothesis that those individuals are somehow self-medicating with nicotine, right? So the idea here is that if you have depression or schizophrenia, that you're using nicotine to somehow manage symptoms, right? And so if I take your nicotine away through a policy, am I going to exacerbate your psychiatric symptoms? Right? And that's a very serious concern. It could be a large unintended consequence of a policy like this. So when I think about this issue, the place I start with is, well, how strong are the data on self-medication hypotheses? And more importantly, how strong are the data related to the fact that we're likely to produce a significant disruption in somebody's functioning, that is an unintended consequence that we should be worried about if they're exposed to less nicotine. And so one way to think about that is, okay, what happens in psychiatric hospitals? Well, what we've mostly learned is that they generally can go smoke-free without major problems, right? Even though they're housing some of the most ill of the people we're worried about. We also know that for some psychiatric conditions, like depression, symptoms actually get better when you quit, not worse. And so we shouldn't just assume that this self-medication hypothesis is actually...
And same thing with schizophrenia.
And same for schizophrenia, absolutely. And then we also know that if someone is doing worse, that there's other ways we can give them nicotine that are less harmful, like a patch, right? That might mitigate some of those problems. So I think the first thing we should do is question our assumptions that this could be necessarily detrimental to them. That doesn't mean we shouldn't ask and study what happens. It's an important question, but we shouldn't assume the conclusion. So these are some data with schizophrenic smokers. These are from Jen Tidy at Brown, where she looked at smokers with schizophrenia who were allowed to either use their usual brand cigarette, a low nicotine cigarette with a placebo nicotine patch, a placebo transdermal patch, or a low nicotine cigarette with an active patch, and studied a couple of different things that are worth noting. So the first thing you might worry about is that someone with schizophrenia, who we know smokes harder and smokes more than a normal smoker, one without schizophrenia, then maybe these folks would be particularly prone to that compensatory smoking problem, right? That they're really going to puff these cigarettes hard and to try to find every bit of nicotine they can in it. So that would be reflected in an increase from usual brand to the VLNC, and you don't see that. You see that on average, those with smokers with schizophrenia take more puffs and at a larger volume than those who are controls. But the manipulation of those within the schizophrenia group suggests that they're not smoking in a compensatory way. Right? Is that clear? So, how about deficits? Do we see, for example, cognitive deficits when you switch people to VLNC cigarettes that are somehow worse than smokers with schizophrenia? So again, you can see that those with schizophrenia tend to have a slower reaction time on the CBT task and have more omission errors in the sustained attention measure, but that when you give them a VLNC cigarette, they show a similar decrement, right, to the control subjects, not a bigger effect. Now the additive part could still be important, right? It still could be that it doesn't really matter if in other words, if I'm a smoker with schizophrenia and I have trouble with sustained attention, and switching to a low nicotine cigarette makes me have even more trouble, then I don't have to have a worse effect than somebody else because I started off at a worse baseline. So maybe that's still important clinically. But that it's mitigated by nicotine replacement. Right? So there's other ways for us to think about this than having to get nicotine through the cigarette. How about affective disorders? So there's certainly a concern here that those with affective disorders already are coming in with a baseline mood disturbance, and that nicotine withdrawal is going to add, at the very least, maybe synergistically to that mood disturbance, and that could put them at risk. Right? But again, as we've talked about before, what we know chronically is that people with depression tend to get better, not worse, when they achieve abstinence. We've looked at this in our trial. We couldn't look at smokers with schizophrenia in the bigger trial, although we have a trial that's being written up now with that population. But we could look at individuals that had elevated depression at baseline and ask, does using these low nicotine cigarettes over 6 weeks make their depression better or worse, or nothing? And what we found was that those who used the low nicotine cigarettes actually reported a reduction in their symptoms of depression compared to those who used the normal control cigarettes, consistent with the clinical literature that depressive symptoms might go down, not up, as we reduce nicotine. And these are data, so you can say, well, that's two populations, smokers with schizophrenia and smokers with depression, or at least depressive symptoms. If we think more broadly about vulnerable populations, you could include people with comorbid substance abuse disorders like opioid abuse, those who are from a socioeconomic background that might be more disadvantaged. And so what Steve Higgins in Vermont has done is collapse these vulnerable populations in a paper that was recently published, where he asked, well, in these vulnerable populations, would they benefit in the same way? That is, if you reduce nicotine in a vulnerable population, are you likely to reduce their smoking? Because we shouldn't just be concerned about the harms we could cause, we should also know whether they might benefit from nicotine reduction, because they also are likely to suffer the health effects, right? And what he found is that much like smokers without psychiatric disorders or vulnerable populations, you see that there's this huge difference in how often they'll choose a low nicotine cigarette versus a higher nicotine cigarette. That's very orderly. The bigger the difference, the more they tend to prefer the high nicotine, suggesting that the abuse liability of these low nicotine cigarettes in these vulnerable populations is probably very low, meaning they're probably not going to smoke them either, not very much, much like the general population. Okay, and then we see the same thing for our smokers with depressive symptoms. They show us the same decline in the number of cigarettes they smoke in our trials, even though they reported elevated depression in baseline. All right, so the third take-home point is that vulnerable populations may also benefit from nicotine reduction without any significant harms, at least how we've measured it so far. There's a lot of trials underway that are looking at this because this is a very difficult question to ask. And our trials weren't designed really to do that, so we'll learn a lot more, but I don't see a lot of evidence so far to suggest that this is a major concern. Okay, again, I'm going to pause and take questions if there are any so far.
So, I mean, you've been talking some about like smoking satisfaction and that kind of stuff. It seems like a lot of the stuff you've been presenting has to do with more like positive reinforcement. Mm-hmm. Have you asked about more like negative reinforcement models and like if they're less satisfied that way? Like if it, like, do you think it regulates your mood less, things like that?
Right, so it's a really interesting question. So we certainly have measures that would I think tap into some of those negative reinforcement processes. My reaction to that is I'm pretty sure that what they show is much the same pattern. That people will report kind of reduced indices of negative reinforcement, say relief from withdrawal, with the low nicotine cigarette than they would in normal nicotine cigarettes. And then both processes are high.
But what not, I mean, maybe not withdrawal processes so much, like even, you know, like more things like in a response to like a stress or something like that.
Right. Don't know the answer to that. That's a really good question. So if you set up the situation right so that somebody was smoking to reduce some, we'll call it a symptom for lack of a better word, but some situational state that's aversive. And how does that play out? I've not done a lot of that. There has been some work, I think Laura Giuliano did some work, and what she found, I believe, was that if people expect there to be nicotine in it, then they get the same symptom reduction. So it's more about their expectancies than it is about a drug effect. I think Ken Perkins had some similar data.
Cool.
Okay, so now I'm going to just touch on the other three things just a little bit. So the first is this, okay, so if the FDA does this crazy thing, moves forward with this policy, what do we need to do to educate people? Like, how do we tell people about this reducing nicotine? So one problem with the policy is this link between what nicotine does and harm. And so these are data from our trial that support a more general observation that people confuse nicotine with harm in a very direct way. They assume that the harm is largely caused by the nicotine. And so certainly there are some things that nicotine does that could be detrimental. But it's a false assumption for them to assume that, for example, a low nicotine cigarette is safe. And that could be really problematic, right? So these are data from the trial where we've asked people what they thought the nicotine content of their cigarette was, right? And what they think their risk of lung cancer would be if they used that product. And what you can see is that the lower they thought the nicotine content of the cigarette was, the lower they thought the risk of lung cancer was. And that's true for other disorders as well, so heart disease, other pulmonary diseases. And in fact, if I were to plot on this axis the actual nicotine content they got, that's irrelevant. What matters is what they thought it was, right? Suggesting that this is an educational problem. This isn't about like whether nicotine hits my throat in some way or in my lungs and makes me feel some way. This is about, if I think it's low nicotine, I think it's less harmful. And so this is really an important target for public education. We would want to correct this problem. It's made worse by potential advertising or other communications, right? So this is the ad that was associated with a low nicotine cigarette in the past, the Quest cigarettes. And Andrew Strasser and Bill Shadle have both been working in this area looking at how the ad and how advertising can affect risk perception in products like this. And what they found was that the fact that it has a blue box and has this little step down thing drives a risk perception that's false. That if you change those components, turn it into a darker box, a black box or a white box, change the structure of the ad, that people don't get that false perception in the same way. So there's an interaction between people's perception, the marketing, and then their harm perception that I think we would need to be aware of. And potentially, if you regulate nicotine content as a product standard, you might also want to ensure that the marketing around that product standard that's allowable can't implicitly or explicitly infer reduced harm. Is that? Okay. The other part of public education that I think is important is simply around the policy itself. So you might find it surprising that in almost every survey that's been done, people are generally supportive of this idea, smokers included. So if you ask smokers, what do they think about a policy that would reduce the amount of nicotine in cigarettes? By far and away, the majority say they would support such a policy. Now, you can say, well, maybe that's because they have no idea how bad it's going to make their cigarettes. That is, they think it's like a free pass, right? They think they're going to continue to smoke and then one day just be able to magically quit like they've always wanted. And they haven't tasted them because they don't taste as good. Well, even that's hard to imagine because we actually asked this question at the end of our clinical trial, after 6 weeks of using the product. And even those folks that were in the low nicotine condition and who thought they were in the low nicotine condition said they would support such a policy. So, this is a complex issue for people. What they do in their personal life can be quite different than how they view a policy. So we shouldn't assume they're going to revolt, right? And instead we should be kind of trying to leverage this in the best possible way. That's not to say there's not a minority that isn't important, right? So certainly some of those folks say they would oppose it. And when there's 40 million smokers in the US, and 20% say no way the FDA should touch my cigarette, you got a lot of people marching on Washington, right? I mean, this is not, we can't ignore that minority. So I think in thinking about public support, there's a couple things we would need to do. We need to correct those misperceptions about harm. We need to clarify some of the science, even the public health community, their false intuition about what's likely to happen, that people are going to essentially be zombies, those with psychiatric disorders are going to be put into complete chaos, that somehow it's just going to be the worst thing that ever happened. And instead try to use the data as much as we can to correct those errors. The other part of this is that for those people that oppose it, to understand why they oppose. And my gut is that the majority of the folks that oppose it are opposing it because they oppose the concept of prohibition. That they see this as a consumer choice issue. And so we need to think very long and hard about how we can pursue a policy that we're pretty sure could potentially be a huge public health gain, knowing that people are sensitive to this issue in the United States, and that we need to be thoughtful about the pragmatics of implementing a policy given that background.
So, I get like wanting to correct the misperceptions. Do you think some of those people who actually are supporting the policy though, are supporting it because they think the low nicotine, I mean, do you think some of the misperception that it's healthier is actually making some people more supportive of it? And if you actually like corrected it, it's like, actually this isn't any healthier for you, they're gonna actually be like, actually, we don't really like that then.
Right, no, it's a really, and honestly, I don't think we've looked at the data from that angle, and I think it's an interesting idea. So if we correct these misperceptions, we could actually step back in terms of the amount of support because they think they're getting a better product, a safer product to use.
Potentially.
Yeah, no, it's very true, it's possible. And so I don't know the answer, and I don't know if any data would speak directly to that yet. It's a good point.
Well, they are, you're getting a safer product in a way through, you know.
I mean, that was gonna say the
So-
same thing, like, so we're not reducing harm in regards to cancer or specific diseases, but we are reducing addictiveness, right?
Right,
I mean, there is a benefit.
right.
So if
Well-
you're gonna market it, you would want people to switch.
And not just that,
Right.
nicotine is like a tumor promoter, so if you reduce the content, then you've made other
Right.
gains, right?
Right, so there are some potential direct health benefits. So tumor promotion is one possibility. Certainly the reduction even in NK exposure could be considered a potential benefit. But the vast majority of the benefit we think is indirect, right? It's through behavior change. And maybe people factor that in, I don't know. It's a hard question to ask somebody. Like, are you telling me you think it's reduced harm because you think you'll smoke less, or because you think if you only smoke this product, it's actually less harmful, right? Because the product's still harmful. The benefit comes from not using the product.
It just really complicates your messaging because
It does.
you don't want to say it's safe, but you do want to say that it's a preferable product for smokers,
Right.
potentially.
Right. And so from a policy perspective, the way I think they're approaching this is this is a policy that's likely to be a policy that leads to improved health by leading to product switching or abstinence. And they've kind of avoided the issue of how they view that, kind of inferred that you got to stop using that cigarette.
So very similar to the harm reductionist kind of marketing that the e-cigarette kind of proponents have put out over the years.
I think it becomes tied to that pretty quickly. I don't think it necessarily has to be that. I mean, certainly there is, if you believe that some portion of people will choose to stop smoking or be less likely to relapse when they do make a quit attempt, independent of using other products, that they might benefit too. But other people will switch to other products. And so the messaging does in fact include something about that. And I think that's why FDA's packaged it that way. Okay, real quickly, because I think we're almost to one, this issue of gradual versus immediate reduction is really important. So if you're going to do this thing, do you step it down or do you just pull the Band-Aid, make it hurt, but get it over with? So we just finished a trial. These data are under review now. And so of a 10-site trial again, 1,250 smokers that were randomized to one of 3 groups. They either got a normal nicotine content cigarette for 20 weeks now, so we've extended the duration of the trial. They got a step down through these various doses over the 20 weeks, so they were on a different dose each month. So first 4 weeks, next 4 weeks, next 4 weeks, and so forth. Or they were immediately reduced to the lowest level of nicotine for the full 20 weeks. Okay, so big study, 500 people in each of those 2 groups, those 2 ladder groups. So these are the key findings. So these are cigarettes per day. What do we see? Well, here's your control group, the gray triangles. Much like before, when you give people free cigarettes, they smoke a little bit more, and they kind of stay at that new level of free cigarettes throughout most of the trial. If you gradually reduce nicotine, they go up, much like the control groups, they near them until you get to this intermediate dose, in which case they might go up a little bit. And then they start to come down, and by the time you get to the 0.4, for that last month, they're at levels of smoking that the immediate group was pretty much at the first 4 weeks. The immediate group takes a month. They're smoking less, but not less than baseline, and they show this decline over the 20 weeks, so that by the end of the trial, they're smoking substantially less than both of the other groups, suggesting that there's a benefit of immediate reduction in that you get to this decreased smoking much faster. Maybe these guys, if you kept going, would have merged out here. We don't know that, but certainly you can see it in the immediate group.
Do you have any differential dropout between the groups?
We do, and I'll show you those data. So I showed you that little peak up in the gradual group, in that intermediate dose, looked like they were smoking a little bit more, and I mentioned earlier that maybe if you go to intermediate doses, you get compensatory smoking. So these are biomarker data. These are metabolites of acrylonitrile, so this is a toxicant that's in smoke that we think is a pretty good marker of smoke exposure. Okay? And so what you can see in that gradual group is they mirror the control group till they get to that intermediate, and here they have more exposure to the toxicants, not less. And so while the immediate group is getting a decline in smoke exposure, the gradual group goes through a phase where they're getting an increase in toxicant exposure. That's what we worry about with the gradual, that you put them by definition through a period of time where you might do harm before you do good. I'm going to skip these just for time, except for this one. How about abstinence? Just to come back to this issue, because it's a longer, bigger study. Maybe we can look at abstinence better here. What we found was that in those individuals who were randomized to the immediate reduction, reported more days of smoke-free, they were smoke-free throughout the trial. Okay, so we do see evidence of increased abstinence. Okay, what's the downside of immediate reduction? Because I showed you the benefit, you avoid the harm, right? The downside is kind of what you're implying, which is maybe it's a little bit more difficult. So this is withdrawal symptoms. They peak in the immediate group and are elevated for a few weeks compared to the other two groups. These are weekly withdrawal symptoms. When the gradual group gets down there, they don't show that peak. You're weaning them off the nicotine, essentially, right? So you don't get the increase in withdrawal. So there is one downside. And that might be what's driving a slightly higher dropout rate and a slightly higher rate of non-compliance in the immediate group. So we do see evidence of both of those. So immediate looks good, except it's harder, right? So it avoids some problems, but it also causes people to drop out or seek other sources of nicotine more often. So for us, when we put that together, we think that immediate is still likely to be the best approach because it's hard for us to get our head around justifying increasing exposure to people, but that these alternatives might be really important if you're going to do the immediate, because you're going to have more people who are looking for other sources of nicotine, who might be going through withdrawal as potentially as the reason they're looking, and you need to manage that somehow.
So I have a question, Mary. For the immediate versus gradual, I didn't review your paper or whatever, but like, didn't like a reviewer say like, it's really interesting, but in terms of the policy significance, it's not realistic. Like the FDA wouldn't say, okay, cigarette manufacturers,
Right.
for the next 5 weeks,
Right.
you can go down to this.
Right.
I mean, this will be like, it'll be like years apart.
Right, absolutely. So this is clearly a model of a process, right?
Yeah.
It is not the process as it would play out in the real world. You can't do that study.
Yeah.
We don't even know what that study would look like, because we don't know how long the steps would be, what other problems would occur along the way. So it's not meant to replicate exactly what it would look like, but there's no reason to believe the processes wouldn't be similar, right? I mean, I think that the idea of titration down, of detoxification, essentially, this just underlies the reduction,
Yeah.
is applicable to a monthly step down too.
Maybe the problem is once you get to that intermediate dose, if people smoke an intermediate dose for a year, they might increase their cigarettes by 5% or 10% for that whole entire year.
Right.
Yeah.
Right.
So that probably.
Right, and in fact, when we analyze those data, we analyze them as area under the curve in part because we want to describe the entire process, and you can think about it on whatever time frame you want.
Mhm.
Okay, I'm just going to say a couple words because we're out of time almost about this, and I'm going to skip to the gist and say that we've run a couple studies on alternative sources of nicotine. This is an unpublished study that we're writing up now, and this to me is probably the most important graph from it. So if you give reduced nicotine content cigarettes in this trial, smoking goes down again. The patch doesn't add that much, so if you're on a low nicotine content cigarette, you wear transdermal nicotine, you still smoke less than the controls, but not a lot more than, it's just not helping more than that. But what the patch does do is it decreases non-compliance a little bit, so it helps people potentially manage the reasons they're cheating. But it doesn't put non-compliance to the point of the controls. So in other words, wearing a nicotine patch will help people with this transition in all likelihood, but only some of them. It's not making it easy. It's not making it like a normal cigarette. There's still 50% of people who are cheating, even on a 21 milligram patch. And then the other study I want to just mention is one that's published in the literature, so you can look it up, that Dorothy published, where she looked at when people get other products, in addition, access to these other products at the same time they get nicotine reduced. And those products could be smoked, combusted products, or they could be both non-combusted and combusted products. So these are the non-combusted products, which include low-level or first-generation e-cigarettes, smokeless, and NRTs. And what she found was that, again, you give people low nicotine cigarettes, regardless of what condition they're in terms of the alternatives, they smoke less. That's good. So it's a very robust effect, and they report decreases in dependence and increases in quit attempts. But what she also found was that if you reduce nicotine, what you find is that you drive people to be more likely to try those alternatives, especially e-cigarettes. And if they try those alternatives, they're less likely to smoke. So there seems to be this kind of, you drive people to alternatives by reducing nicotine. If they engage with those alternatives, you also seem to see a decrease or an increase in the number of days that they're abstinent from smoking. So when we think about alternatives, I think we need to think about this potential relationship as being bidirectional. Okay, so that's where I'm going to end. This is the quote that from last July from Scott Gottlieb, Commissioner Gottlieb, about this policy and how they view it, which clearly it targets the addictiveness of cigarettes, but also puts it in the context of these alternative sources of nicotine. That's what they're selling. And we need to decide as a community how we feel about that. And to that end, as I said, today, this morning, this gets released, right? The docket is open for 3 months. This arguably is one of the most important potential policies we will ever see related to cigarettes. And so if you work in reduced nicotine and you want to comment, that's great. If you work in other areas that have data that are relevant to some of the issues, I would absolutely urge you to comment on this, whether positive or negative. It's a huge, huge policy issue. And everybody needs to contribute to this discussion, not just those of us that do this all the time. So that is it. Happy to take more questions.
Last point. So this is part of a general, broader harm reduction discussion. And so the harm reduction discussion, I just came back from the World Conference, is very focused on e-cigarettes so kind of what you're pointing at, I mean, I'm thinking, okay, so we take the nicotine out of combustion and we add the nicotine into vapor, and you're saying yes, in fact, that's actually a strategy, and
so what's your target? To me, it depends on what your target is. If your target is to reduce smoking, then I think that is in fact a strategy. That reducing, if you were to ask me, does reducing nicotine alone, is it likely to lead to the same reductions in number of cigarettes per day or smoking compared to reducing nicotine and providing a viable alternative? I think the answer is you'll get a bigger effect with the viable alternative. Now that's if your target is smoking. If your target is broader than that, you may come up with a different answer. But if your target is combustible products, I think to me it's a relative reinforcement issue. You have 2 products people can choose to use. If you degrade one, that helps. If you allow the other to compete with that degraded, that probably helps even more. So it's a tough answer because it means that, but I think if that's the target, that is the most effective likely policy from a combusted product perspective. Yeah.
It's all, we had this discussion this morning. It's all in the context of cessation, and not in the context of initiation.
Mm-hmm.
I think there, if people were just choosing between cigarettes and e-cigarettes, everything else were the same,
Right.
and, you know, you had a fixed pool of people that would use one or the other, then that would be the case. But I think, you know, the evidence to date is that e-cigarette use promotes, availability of e-cigarettes promotes the initiation of cigarettes.
Right.
But if the cigarettes suck, maybe they
Right.
wouldn't.
Right,
That's
I think
that's a huge gamble.
Right. I think the issue of is nicotine reduction sufficient is different for prevention. So it probably is enough, nicotine reduction probably is sufficient to drive down, to improve prevention efforts, unlike cessation where I think you might need both. Yeah.
Saw the presentation the other day when you're showing the topography of Juul, whatever, you know, we've all been talking about, you know, and it really mimics combustible cigarettes very nicely. I mean, not nicely, but closely. And since it's something that youth are clamoring for, it does present the possibility that if cigarettes do suck, they won't necessarily go back to combustible, but they'll do Juul with really high levels of nicotine.
Right, right.
And so it's maybe replacing, from a prevention standpoint, it's replacing one problem with another.
Right.
In a sense. Is that-
It could be, right. I mean, that all depends on how problematic Juul or anything else is, right? So, but certainly from and so I don't want to couch this as those aren't issues to worry about. They absolutely are. The use of those products by youth and the potential problems associated with be it addiction or other harms is real. Is that problem greater with the availability of combusted cigarettes? Or, you're right, so even if it's not a perfect solution, this is the world we're kind of living in right now, right? And so if you can avoid if it's a gateway effect, whatever we want to think, whatever catch term we want to put on it, if that's what's happening, if you can avoid some of that process and avoid the transition to combusted products, I think you'd be hard pressed to argue that's not a step in the right direction. Right? I mean, not that I wanted a kid using Juul. I've got an 11 and a 12-year-old, but I'd be horrified if I found they were Juuling, right? But if they're Juuling, do I want to take away the possibility that they'll actually become a Marlboro user? Absolutely. Yeah.
Don't you think that if cigarettes, the nicotine in cigarettes become negligible, like the lowest dose, right?
Yep.
That are functionally zero.
Don't use that term again.
Yeah.
You're on tape.
I know, right? Exactly. Well, no, there's a bimodal distribution, but then through other ways, we think that that's the lowest. That's what we should do.
Right.
There's other supporting data. Cigarettes will end like in a couple of generations, right?
Right.
There's no, like, unless there was some weird social shift or something, or cultural drive to make smoking popular, if you take away the nicotine, you know, that's like taking the what do you call it? And Vicodin, whatever, the oxycodone out of Vicodin just becomes Tylenol. Like, no one's going to abuse it.
Right. Right.
But some people are worried because, like, at the end of the trial, they're still smoking in the trials that you do over 8 weeks or whatever, 16 weeks. But like over time, if you just give people enough unreinforced smoking trials, and then in the future, the new people try this product, like, shouldn't there even amongst the adult smokers be deconditioning?
There should be. If condition,
like 10 years, it's like, it's gotta.
right. And at some point, you've certainly degraded the pharmacological effect, and you've degraded the conditioned effect as well.
Right.
So there are other reasons people could continue to smoke, but it's likely to be a very small number of people. And if those people choose to smoke freely under those conditions, then maybe that's okay. The problem I have is that they're not choosing freely to continue to smoke, right? So I think if you want to couch this as a prohibition versus consumer choice issue, this is about giving freedom back. It's not about taking it away. And so I agree with you. I also think we have to be really careful not to assume it is just going to be a magical solution. People do, I mean, I've sat in these trials, and people run through them, people will go through and say, yeah, they're not so bad. And I'm like, what would this person do? Maybe that person would keep smoking for a pretty long period of time. Maybe it doesn't reach everybody, and that's okay. There are lots of people it would reach.
Maybe we need to understand why, like who those people would be, why, right?
Right.
Even if it's like 5% of those smokers.
Right, that might be the next big question, if they actually move forward, is who's left. But-
And I imagine on the comments, I mean, there's going to be a lot around smuggling and like broader policy issues, because obviously this is not a global policy, and nicotine is going to continue to be used heavily in other countries.
So the smuggling, there's two big issues that I think people gravitate towards. The one is the compensatory smoking, which is frankly a terrible argument because it's based on no data, and all the data to the opposite. So it's just it's a gut reaction that's not informed by data. The other is the illicit market, and that one's real. That one is, okay, there would be an illicit market. The question is how big and what do you do about it? It's not a question of if, it's a question of mitigation. And so, what are the mitigating factors? Well, certainly you can try to control supply, and that would be necessary. And distribution. You want to think about how products are moving around and tracking them. But the other thing you control is demand. And that's, again, where you have to think, what is the role of alternatives? Is it to reduce demand for illicit? It's tricky, and all this is in the context of what's going to actually happen in Washington, not just scientifically what would happen.
I mean, I think that's a more persuasive argument for having alternatives than a way of hastening people to quit smoking. I mean, as Adam says, I think it's sort of the subtext of what he says, we don't need e-cigarettes. I mean, it may make it a little slower, but if you just reduce nicotine content, people will quit smoking and people will quit starting.
Right. I think that's true. I think that is probably the stronger argument for alternative products. I think there's two for me. One is the impact on illicit markets, and the other is simply a social message that it's not prohibition. Because if it gets tagged as prohibition, it's dead. This is not a country going towards prohibition. Any other questions?
That's great.
There are many problems. Cigarettes.
See, but like these are very proud.
I don't watch TV so much.